Assalamu alaikum. Good afternoon, everybody. I would like to welcome Dr. Gorka Sesma. Dr. Sesma he did his medical college on Caracas Central University in between 1984 and 1991. Then he did his postgraduate training in the same university between 1993 and 1996. And he did pediatric strabismus fellowship and the same at the Caracas University Hospital between 1998 and 1990. During the 1998. Later, he joined the Baylor College of Medicine, Houston, Texas Children's Hospital, where he obtained pediatric ophthalmology, joined the pediatric ophthalmology, and he got the pediatric ophthalmology fellowship from there. Dr. Sesma been with us since 2016, and he worked very hard with us. Dr. Sesma has a special personality. He is very kind, gentle, strong, resilient, caring, assertive. Is very hard working staff, reliable, honest, and practical. Very responsible and loyal to cases and to patient, mature, creative, consistent, and he is very sensitive, perceptive, patient, thoughtful, fit, trustworthy, and very motivated to teach, educate, residents, and fellow. He has excellent surgical skill regarding intraocular surgery and strabismus, and I would like to welcome Dr. Sesma today for his presentation, Birds and Tips in Strabismus Surgery. Welcome, Dr. Sesma, to the ground round this afternoon.
Thank you, Dr. Mesfer, for the nice words, and I really appreciate. And thanks to all the audience for coming and participating in the lecture. More than a lecture, I found this notebook in my library, and I want to share with you some experience during years in my career. The first thing that I would like to start is that this is my approach to the strabismus surgery. It doesn't mean that it's the only approach, or we have many ways to get the same results. So I want to share with you this experience. You can hear around when you walk in the hallways, you can find people that says, you know, strabismus surgery is so easy. The most difficult part is make the surgical plan. When you listen that, you could think that this person that is saying these words doesn't know what is he saying. You know, strabismus, like any specialty, like any activity in the life, require study, efforts. And when you listen, especially the residents that are here, when you listen that someone tell you these words, think that this person doesn't know what he's talking about. So I like the approach of these books. Probably many of you can agree or disagree about this approach, but I like the way when you learn through these books, no? Because it's a practical way, it's an easy way, and we're in the 21st century. We are dealing with millennials, and the way that we teach and the way that we learn should be changed. So why not we can do something like this, for example? I'm pretty sure that we are going to do it in some point, this book, The Strabismus Surgery for Dummies. In Kekesh, we can do it. But before to do this, when you teach and when you learn, we need to understand something. We need to build an structured simulation curriculum. We need to get objective assessment of getting skills, knowledge. And for that, the book is an option. But what about if we do an strabismus course in Kekesh? Well, let me tell you something. We are preparing this strabismus course. It's going to be practical. It's going to be based in the develop of skills and to get confidence, to the residents or the participants get confidence gain competences. That is the most important part of any develop of any skill, competence. So I would like to thank Dr. Carla Al-Saban that has been supporting me in this idea. We are working hard, and probably after this coronavirus situation goes away, you residents of Queques, you will be lucky to have this course. And then later we open for all the residents in the kingdom to give you the opportunity to develop competencies in strabismus surgery. So be ready for that. Let's start talking about some general considerations that can work for, not just for strabismus surgery, can work for any surgical procedure. There is something that we face here in Queques as a teachers, in a teaching hospital, is that the surgical time. One thing that is pretty sure in any surgical procedure is that when you increase the operating time, you increase the post-op complications. So one of the goals that we need to get as surgeons, be good surgeons, is reduce the surgical time. The surgery should flow, and is the way that we learned probably before, that was, we learned it this way, spending a lot of time in OR, because we need to learn. Probably this stage of learning has been modified, and we need to improve it with the wet lab sessions and with the other techniques that we can use to teach. But this is something important, because we are learning the patient doesn't have the fault to spend a lot of time in surgery. In the system of this editorial for dummies, so faster is better. It doesn't mean that we are going to do fast move or fast maneuvers in the surgery. Fast means that we are not going to waste time during the procedure. Second, we need to keep learning. Third, we need to learn about our mistakes. So we have to learn to make insight and analyze what are we doing well or bad. I have a theory that there is a theory shared in many universities about the learning process. This is a graph, and this graph is similar to the productivity that is analyzed when in a factory of cars, or for example, in General Motors. So this is the same graph. The behavior of any number of tasks versus productivity is like this. But what about this? If we are in a learning process, especially developing skills in strabismus surgery, we say something like this. We do wet lab, we make insight, and every time under supervision. Probably this learning curve is going to be increased, it's going to be exponentiated, and we're going to reach the same result in a short period of time. Wet lab is a very, very basic, vital, the most important part of your learning as a surgeon is the wet lab. We here in Queques, we have the facilities, but we can develop wet labs in other places. Yes, this is important. It's like a pilot. A pilot, if he goes to the plane, he needs to go to the simulator before. So the same for the surgery. So this is a proposal. For every hour of surgery, we need to do 3 hours of wet lab. We don't have the facilities, but we can have these things. And in the case of strabismus, we can develop our homemade wet lab. We have here one paper. You have the QR code there. You can picture it, photo it, and you get the link to this article that is going to give it to you. A nice way to how to build a homemade wet lab for strabismus. Or here you have another paper with all the tricks and things to develop this. We in the course, or when we want to prepare an objective way to assess the learning of the process, we are using this system that is called OSCAR. OSCAR was developed by a consensus of many strabismus surgeons, and we use this process that is slicing the surgery in many pieces. And when we slice the surgery in many pieces, we can understand step by step in which step we could have problems, or we're struggling, or we're mastering. So we need to do wet lab. We need to practice, practice, and practice. This is a word that I say to my daughters when they were young, to say, because practice makes perfect. Well, this is true. Insight. It's difficult for us many times make insight. Insight is the capacity to understand that you can make mistakes. And the most important part as a surgeons, because one of the problems that the surgeons face is we have ego. And the ego is our worst enemy, because the ego sometimes doesn't let us have this insight. We learn about our mistakes. And that's important to make insight to start to learning. First thing, record the surgery. Watch videos. Second, study the steps of the surgery, the procedure completely, all the pros and cons of the procedure, all the things about this specific procedure. You need to study a lot. And the most important word here is ask for help. Here we have a lot of consultants, and everywhere that if you are in a teaching hospital, I'm pretty sure that you're going to find someone that is going to help you when you ask them. When you record the surgery, you can, it's so interesting, this, let me tell you a story. A long time ago, I had a resident, I was training him and asking him, please record the surgery. And this resident told me, no, doctor, I'm not going to record the surgery. And I say, why? Well, he told me, I'm going to record the surgery when I perform the surgery perfectly. So I say, this is an incapacity, total incapacity to make insight. You need to record the surgery, because when you record the surgery, you're going to see where are your mistakes, where are your advantages, and incredibly, you can exponentiate your learning. And so this is important. So here in KKH, we have this capacity, but you can do it. Record the surgery. Second, once you record it, go home immediately the same night and watch it and analyze the video alone. And the most important part is this one: analyze it in group. You can do this procedure. You can watch these videos in a weekly session and discuss the procedure per se. And let me tell you something: you're going to learn a lot, and you don't need to perform 100 surgeries to improve. With these 3 steps, you can learn and you can improve your skills. Supervision is basic. Here in KKH, we have, in my division, we have consultants totally different, but all of them are available and very supportive when you need them. And we have different ways to teach. We have, for example, persons that teach us in our division, telling us stories, or persons that usually don't speak, but when they speak, they give us lectures of wisdom in 140 characters, or people that tell us, no, I'm not experienced, but they are very supportive and they teach us the safest way to do a surgical procedure. Or keeping curious. So in every hospital, in every place that you are learning, you're going to find every time someone that is going to teach you. So the most important part in this part is that you count on these people, ask for these people, squeeze these people, because I'm pretty sure that we as teachers, every time that we teach, we learn. So listen and learn from your supervisors. This can apply for strabismus, but apply for any subspecialty in ophthalmology. After this, you can decide as a resident or as a fellow. You can challenge yourself or you can find excuses. You decide. One important thing as a doctors is that we need to use this basic principle in the medicine. That is, first, do no harm. This is the basis of the medicine. But I would change this for this. Please do no harm. No, because I'm learning, I have the right to harm. First is the patient. Second, more than learn, is the safety. More considerations. This is common that we find in the way of teaching the perfectionism as a goal. Well, let me tell you something. Perfectionism shouldn't be a goal in surgery. Safety should be the goal. Then, when you become in a safe surgeon, you will be perfectionist, because perfectionism is too close to the disaster. It's funny when you are finishing a surgery. Let's suppose a cataract surgery, and the surgery is done, and you say, you listen this. No, doctor, let me aspirate this little part of cortex. What happened? The capsule is broken. So avoid the fellow syndrome. Be safe. When we do a strabismus surgery, we need to know all the steps in advance. Thinking in advance, knowing all the steps of the surgery in advance. Improvisation is not allowed. Not because you are R1, R2, R3, or F1, you have the right to do the surgery, and when you go there, you don't have idea what are you going to do. This is irresponsible and unacceptable, and improvisation is not allowed as a surgeon. All the steps are important. If I ask you now, what is the most difficult step, for example, in the cataract surgery, I'm pretty sure that you're going to answer to me that is the rhexis. But what about if you don't place the eyelid speculum correctly, or you don't drape correctly the patient, or you don't do the incision correctly? You're going to struggle during the surgery. So all the steps are important and vital to have a successful procedure. You need to know in every step of the surgery that you have enemies. So you need to identify them in advance. Here is something that is a nice paper written by Dr. Trader in 2000. It's about the 11 commandments of the teaching of ophthalmic surgery. You could say, well, usually there are 10. Well, this doctor, and I invite you to get the link, read this beautiful article about our job as a teachers, as a learners, because we are in a teaching hospital. So this guy divided this article or these commandments in 11. 5 for the residents, 5 for the attendants, and 1 for the head of division. We, in this audience now, we have residents, fellows, attendants, and head of divisions. I invite you to read it. It's pretty, pretty nice. When we have the surgery and we are facing as a first time our procedure and entering in the strabismus procedure, we are like this. It's a big puzzle. And we have a lot of steps and decisions and problems. So when we see this, we start to feeling decompensated because we have many variables, many steps, many things. So we can apply something that Julius Caesar tell us long time ago: divide and conquer. If we, instead of having this all big problem, we divide the problem and we divide it in small pieces, like Oscar procedure, I mean, the Oscar, this way to assess the surgery. If we divide it in small steps, I'm pretty sure that we're gonna, instead to have a big, huge problem, we're gonna have small, little problems. Facing each one, I swear you that you're gonna improve fast and quick. So this is Oscar. We divide, for example, the strabismus surgery in these steps. So if you divide the strabismus surgery in these steps and you analyze each step one by one, and for example, you analyze the time that you spend doing this, the way that you are doing this, the problems that you're facing doing this, the number of maneuvers unnecessary or necessary that you are doing during this specific step, you are gonna get amazed about how many mistakes we made in the daily surgery. And if we improve these small things, we can improve a lot the procedure. In the stock world, we say something that is, plan your trade, then trade your plan. Well, in strabismus, it's the same. You made the strabismus surgery in the office. You need to know after you finish your clinic with the patients, you write a clear plan. What are you gonna do? And you are not gonna do this in OR. When you go to OR, you already has a plan, and this plan should be written clearly in a visible place in the OR to avoid confusions. So the surgery in strabismus is done in the clinic. These are the table that personally they use. There are many tables. Marshall Parks, Ken Wright, David Coates, many numbers. You can take this, keep it with you. You can keep it, for example, in OR if you don't have fun. In the time, in the pre-era of internet, you know, I have this table. I have it in my pocket. I reuse it, I plastify it, and I keep it in my pocket to check my numbers. But now we need to have these numbers as a recipe to do the surgery. Also here you can see the other table that is used for example, for vertical surgeries, or for in case that you need to do Kestenbaum procedure for nystagmus, you have the numbers here. So before entering the surgery, you can operate the groin patient. You can also operate the groin eye. You can operate the groin muscle, or you can make the groin procedure. So this is terrible, and you know, happens. How can we avoid this situation? We can avoid this situation with small tricks. First, identify the patient. Second, write the pain diagnosis plan in a visible place in OR. Check the information before the surgery, and be clear of it. Don't be, I mean, you see the plan in this board, we're using Kekesh this way, but you can write it in a paper, visible, easy to check. For example, here you see that the patient has an XT of 80. It's important to write the diagnosis, the angle, and the procedure, because you could be nervous and you can mess it up. We can to do the surgery. We can do the surgery to view the surgery. We can use many instruments. For example, we can do it without loops, but we can do it with direct visualization, or we can use this 3D visual visualization system. You know, one day when we were doing this procedure, one doctor came to my OR and said, "Why are you doing, or why are you using this system for the strabismus surgery?" And my answer was, "Why not? We can take the advantage of the technology to improve the procedures, and it's possible. So we can do it, why not? But also, we can use direct visualizations, loops, or other techniques. So this is the idea. One consideration regarding loops. Many residents tell me, "Doctor, I don't know how to use the loops. And sometimes when I use it, I get dizzy." Well, you get dizzy because probably you are using the loops in the bad way. The only moment that you look through the loops is just when you need magnification. For example, you need to pass a stitch, you need to make a knot, but the rest of the time, you are not gonna use the loops. The other thing is the magnification. You would like to have plus 4x of magnification, but what happened? You could have bigger magnification, but you're gonna have less distance of work. For example, if you are a dentist, you can work with +4 because the distance of work is shorter. In ophthalmology, my recommendation is use maximum 2.5x and look through the loops just when you need to watch this. There are some brands, I don't have commercial interest in this. For example, eyelid speculum. Do we need to use any special eyelid speculum strabismus surgery? Well, I could tell you yes or not. Let me show you this. Move it to the other side, to the other side. Keep going. Okay. When we have this type of eyelid speculums, you look at the rotation that we have, and especially in kids, we have this situation. So I prefer to use this type of ID speculums for strabismus. You avoid the rotation. What is the problem of this? That when you rotate, you can be disoriented. Sounds crazy, but you can be disoriented. And instead to start the surgery in the medial rectus, because you have this disorientation, you can grab the inferior rectus or the lateral rectus. So this is one advice regarding the ID speculum. Then, before touch the eye, you need to watch the surgical plan. You could start the wrong muscle. So you need, before touching the eye, you check the board with the surgical plan. You need to avoid these enemies. And I don't know why, it's pretty common during our learning process that when we see a vessel, we go for it. And I call this vessel the R1 vessel. So avoid the R1 vessel because you have 360 degrees of sclera to grab a forceps. Why are you taking the vessel? If you learn this, I'll be so happy at the end of this lecture. Then, when we place the eyelid speculum, we do the traction test. This video is courtesy of Dr. Mohammed Shanrani, and I'm going to show you how's the way to do a traction test before starting the surgery. In this case, this is a patient who has a left superior oblique palsy, you see? Congenital superior oblique palsy. You see how the eyelid goes loose, and then decide, if you see carefully, you can see that the patient has a left hypo. So we need to do the traction test before start the surgery. There are two ways to traction the eye, using the silk or using the Moody's forceps. Both are valid. My personal preference is the Moody forceps because I'm reducing the risk of perforation with the needle of silk, but it's okay, work. And the advantage of this Moody's forceps is that it's reversible and easy to place and easy to remove. You have the link there, the QR code of this video, but let me show you. I usually perform this procedure is fornix, I do it through fornix incision. I grab the Moody forceps, grab it at the limbus, and I expose, in this case, the inferior nasal quadrant. You can see here that this white tissue in the sclera, and this is going to be the place that we are going to make the incision. You can see also these vessels. Well, these vessels are telling you that the medial rectus is there and the inferior rectus is there. So the incision is going to be between those spaces. You see the white tissue, that's the place that you're going to do it. Second, when we do this, we need to make the incision. The incision should be at 8 millimeters from the limbus. No more than 8 millimeters because you can get the fat. We grab conjunctiva, enough conjunctiva, we peel this conjunctiva, and then the tendon, and against the sclera, we open this space, because what is the goal of this step? We need to reach the subtenon space. At this moment, we need to see that the sclera is clear, and we cut this. Here, when you cut here, you should be careful because you can have fat there. If you have fat there, avoid to cut it. So when we have this space, we know that we are in the subtenon space. This is vital. If you don't get the subtenon space, when you hook the muscle, you will be in the pretenon space. So you never are going to hook the muscle. This is the distance. So as a reminder, 8 millimeters from the limbus, careful with the orbital fat, pull the conjunctiva, touch the sclera with the scissor vertically, one snap cut, not many multiples, one snap cut, and reach the subtenon space. If you don't reach the subtenon space, you cannot proceed with the next step. Let me show you something about hooking the muscle. So the hook is not a rope, and you are not a cowboy. It's pretty common that when we need to hook the muscle, we start to moving the hook like a rope. And you know what happens when we do these maneuvers? We usually split the muscle, usually we break the muscle, we usually hook it incompletely, and the muscle shouldn't be hooked in that way. So you are not cowboys. The first step when we hook the muscle is touching with the tip of the muscle the sclera. Then you go superior in this case, touching, keep contact of the hook every time and going superior. The other thing is you need to enter behind of the insertion of the muscle. If you start to doing this maneuver at 2 or 3 millimeters in case of the medial rectus, you're never going to find the muscle. So go at least 7 millimeters, touch the tip with the tip of the hook, the sclera, go superior, and then you are going to follow these instructions. That is this one. Okay. You use the second hook, and look at this, the position. Never the hook goes down. This is not a rope. This is not a rope. This maneuver that many people do like a rope, like a cowboy, that doesn't, you know, that when you do this, you break the muscle, you complicate yourself. So this maneuver is not. Once you get the hook, you touch, you go superior, and then you go to the medial. This is the maneuver. You have the video there if you want to analyze it later. So one of the things that we face sometimes is we are trying to do a maneuver and the maneuver doesn't work. 1, 2, 3. What happened usually at third time? We complicate the case and we say, you know, I break the muscle. When a maneuver doesn't work, switch, change the approach. This is an important tip that you need to keep it in your mind. In surgery, in these cases, you need to think in advance and you need to try to keep it simple. When you think in advance is when I'm doing this step, what is coming next? So if you're trying to do a hooking and it doesn't work, so switch the approach. Probably you are doing something wrong. And the answer is going to be there. In this case, once we hook the muscle and in the fornix incision, we need to open this space. So the way to do it, once we hook them, we need to open this tenon. So with a forceps we grab it, peel, and vertical cutting, we are going to see the edge of the muscle. Okay. Once we have this, we can cut this redundant tenon. The idea of this procedure is get the complete muscle. This is the way. We need to create an inferior edge, clear, white tissue, sclera. Now we know that we have the complete muscle. In this case, we need to cut the tenon. When we didn't cut the tenon is, when we pass the sutures, the tenon is going to come and it's going to get mixed with the sutures. So the idea is cut the tenon. Look at the vessels. These are your enemies. You need to cut this tenon to try to unplug the posterior tenon from the insertion. Another thing, look at the vessels. These are your enemies in this step. And look at the way that we cut. We cut following the sense of the fibers. The other thing that I saw frequently is here that you can use this maneuver with a Q-tips, is valid. And also you can use the scissor as a pusher. But you know, it's common that many residents I saw very, very frequently that they start to using the scissor as a pusher. And it's good, this technique, but you need to start cutting. So you start cutting and then you push with the scissor. But if you don't start to cutting with the scissor, you're gonna be just pushing and you're gonna be doing anything. So you can use Q-tip, you can use the scissor, or you can use this technique of pushing, cutting, but you need to start cutting. We can use, for the suturing the muscle, we can use different techniques. For example, this is Marshall Parks. You enter in the middle, go to the sides, locking bites, coming back again. There are different modes to do it, all valid. What is important here in this step? In this step, it's important to secure the muscle. The most common question that I receive from fellows and residents when they are starting surgery, strap surgery with me, is, doctor, should be partial or full thickness? And my answer usually is secure. One of the problems that we face in the isotropic surgery is the slippage of the muscle. And this is because probably we are not, one of the reasons, there are many reasons, but one of the reasons is that probably we are not passing and securing the muscle. So my advice in these cases is, I'll do it different. I enter from the edge, but I secure the muscle. So when you pass the sutures, if you are not sure about the muscle, if it's secure, pass again and secure the muscle. This is the most important message for this. I'm going to show you this, the way that I do it. I enter usually from the edges, but it's valid entering in the middle and go back from the sides. I usually use this technique that is reclining the hook and using the hook as a shield. There are other ways to do it, but this is, in my opinion, for the resident, this is a safe step because the sclera there is so thin, and if you have the hook and you feel the metal of the hook while you have the needle, you are not going to face this, the possibility of perforated. Let me show you. So in this case, I enter from the inferior edge and squeeze the muscle, and I go above the hook. And I go to the other side at once. So with this maneuver, I'm just passing at once and I save time. Then I'm coming back and I'm gonna do it twice. Could be partial and full or full and partial, avoiding the vessels. This case is partial, and then I go back. And this is locking. You see, I'm locking the suture and I'm finishing with the lock, securing twice. If you have any doubts, you can pass again. You can pass again. You need to have at least 1.5 millimeters from the edge to avoid the slippage. We repeat the same maneuver in the inferior edge, and we secure the muscle. Analyzing this video, I was analyzing and making some insight about this video. You can see how many unuseful maneuvers I'm using. For example, you see I'm dealing with the needle and grabbing and re-grabbing. So let me tell you something. Every time that you add steps to the surgery, you are adding the possibility of complications. So you need to reduce the number of steps, keep it simple, because you are, with this, you are reducing the number of the possibility of complication. For example, in this case, you see I enter and grab it again. You see, if I, for example, instead to do like this, it will be ready. I grab it with the needle holder and I'm prepared for the next step, that is this one. Save time and the possibility to with the complications. So once we secure the muscle, we are ready for a step. This is a reminder. You can edge, squeeze the muscle, use the hook, and secure. This is the most important part of the final messages. Secure the muscle. You have the link there if you want to get the video for review. Once we secure the muscle, we need to cut it. The way that we'll do it is you keep apart the sutures, because if you don't keep it apart, you can cut it. And we are going to start to cutting the muscle. When we cut the muscle, this is the moment that we use small snap cuts, watching, eyes are watching the suture, because at this moment you can cut the suture. I use the Moody's forceps. They're going to work as a reference. It's a nice way to work with these Moody's, because they give us the inferior edge of the insertion of the medial rectus muscle. Then I place the other Moody, and this is going to give us the reference for the muscles. This little red tissue can be cut to load. Now, at this moment, we need to check if the muscle is not twist, is secure or not secure. This is the moment to check it. Once the muscle is detached, we need to treat it smoothly, because we can break the sutures and we can lose the muscle. So at this moment, we can do different techniques. For example, I use cross sword techniques, but you can use handbag or modify handbag suture. For example, if you are learning strabismus, and the first cases, my advice for you guys is do handbag. Why handbag? Because you reduce the risk of scleral perforation. when you do cross-sort or modify handbag, you can increase the risk of perforation. So, but anyway, you can do any technique. This technique has advantage and disadvantage, and this is not the purpose of the scope of this lecture. It's just to let you that you can do it in both in different ways. The way to do this, I call cross-sort. No, I'm checking muscle is not twist at this moment. I'm grabbing the inferior, and I'm going to enter from superior. I use the Moody works as a mark. It's telling me that this is the inferior edge, and the assistant can help you to clean and to mark. This is important. Clean and mark when you are with the needle ready. I saw many times that you mark when you don't have the needle holder ready. And what happened? Okay, you mark it, but because I was not ready, I need to mark again. This is an unnecessary maneuver. So you're gonna mark when you're ready. The passage through the sclera could be scary, but no, the trick of this is that you need to keep the vision of the needle through the sclera every time. If you lose the view of the needle, it's because you are deep, and you can be in troubles. So this is the cross-sort maneuver technique. I feel comfortable with that. I think it's a good technique. Look at this. If you're pushing too much, the trick is that you don't need to push too much. It's a movement with a small movement with the hand. So we do this. We need to be careful to avoid the get complicated with the sutures. You know, I mean, struggling that. So that's it. We made a knot, and this is the cross-sort technique about this recession. In these cases, you can close the conjunctiva or not. You know, it's funny. Many residents tell me, Dr. Sesma, I saw a patient of you last week in the ER because the patient came with the conjunctiva open. I thought that the conjunctiva was. No, you can leave the conjunctiva open. You can close it. By safety, you can close it. But if you leave it open, the scar is going to be smaller in the time. When you compare this scar year after the procedure, you don't see this scar. You don't see but if you don't feel comfortable, you can close it. I'm not saying, and I'm not trying to sell the idea that I don't close it. I'm just saying that you can leave it open in these cases, especially in small kids, in the BMR procedure, you can leave it. But if you don't feel comfortable, you close it. So finishing this, I would like that you have these references that are going to help you to understand a little bit some tricks or on some person in strabismus surgery. And I'm going to give you 9 words that are going to help you to succeed, not just in pediatric ophthalmology or in surgery. I'm going to help you to succeed in the life. First one, in this case, your residents, your fellows, is go to class, attend the lectures, be active in the active learning process. Second, do your work. Try to do as much as you can to learn. Be responsible. Do your accomplish your responsibilities. And the 3 last words are ask for help. This is probably the most important, and this is probably the 3 words that we are resilient to take it, because our ego and sometimes our situation doesn't allow us recognize that we don't know, and the first step to learn is recognize that you don't know. Final word, home message, keep it simple, think in advance in surgery, and thank you.
Thank you very much, Dr. Sesma, for this is a great presentation. I would like to see, I think that somebody is asking, I don't know if I have to look at their questions, if there is any. I'm impressed that we have about 168 participants, which is a great for the ground round today. Most of the messages are thanking you. I have one question just for you. What is the chances that patient who will under strabismus surgery may lose the vision? Because this is That's not uncommon question by the parents.
So that after strabismus surgery, the patient lose the vision? Hello.
Yeah. Once the patient underwent surgery, what is the chances that these kids may lose the vision in one eye or in both eyes?
You know, this possibility exists. The incidence of loss of vision after strabismus surgery is low. It's low, probably less than 0.01%, but could happen. Could happen. It's a real.
What are the common causes for kids to lose the vision? What is the complication that may lead to the child or to the patient, if he is adult, to lose his vision after strabismus surgery?
Okay, one of the things is could be that secondary to infections, so the patient can develop an endophthalmitis. It's not common, but could happen. And the other thing that we could be aware is the possibility of perforation. And after perforation, the patient could develop retinal detachment, could have a vitreous hemorrhage, the patient could have complications related with the perforation, basically retinal detachment or complications associated to this detachment. No? This is one thing. The other thing that we need to keep alert is if you are performing surgery more than 3 muscles, that is, it's supposed that you never do it, because you can induce anterior segment ischemia, and this can induce decreased vision. No?
I just, before I go through the chatting question, I just came across one case where the patient, this is for the audience, where the patient, especially for resident strabismologist, patient ended with no light perception after strabismus surgery. And the reason behind that is found to be that central artery occlusion. The child was about 9 years old, and he ended with central artery occlusion. And further investigation confirmed that the surgeon did the surgery very well, but after he closed everything, he allowed the specialist, the one who was working with him, to give the subconjunctival injection. The subconjunctival injection was a gentamicin, and I think it's entered, the injection was injected into the intraocular space. As we know, gentamicin is very toxic, and the patient ended with no light perception and central artery occlusion in this case. For this reason, I think, what is the importance of subconjunctival injection after strabismus surgery? Do you recommend it, or it should not be given, or it is optional?
You know, I personally, I don't use it. I don't use it, but it's supposed that before, I don't know, I could tell you that 15 years ago, I used it as a routine, no? Subconjunctival antibiotic, but I have many years without using I don't think that it's necessarily. I mean, personal opinion. No? And also I'm seeing another question from Dr. Semide about traumatic optic neuropathy. Yes, you know, you should be careful, especially in patients when you combine surgery that involve the orbit, and you should be careful about this potential pathology that you could have traumatic optic neuropathy after traction and after, yeah, it's possible. It's not common, but it's possible.
There's one question by Dr. Amal Al-Hamidan regarding the hang-back technique suture. Do you use it or no?
You know, I prefer cross-sword, but it's supposed that when you have a hand-back technique, you could have late overcorrections or unpredictable results. I don't think that you could have, I mean, I don't think that you have late overcorrections if you do it well. I prefer to do cross-sword, but for example, in KKH, when the residents are under my rotation and they are learning, I prefer that they do hand back because it's safer. I don't want that they perforate the eye because they are learning, but I prefer cross-sword if you ask me as a personal approach to the strap surgery.
I just like to ask, as you know, since Botox become part of the management of strabismus, I think I find that maybe 50 or 60% of cases without restrictive and paralytic strabismus, they could do well with Botox injection. Botulinum use of botulinum in strabismus patients, it may reduce the complication. For this reason, I think it is the first line of treatment in certain cases, especially those patients with partially accommodative infantile ET, and even I use it for the overacting oblique. Do you think this is could avoid reduce the complication rate?
You know, for example, in the case of Botox, probably you guys are more experienced than me in the, you know, I learned to use the Botox in this amount of patients with you guys. You know, you are more experienced like me. I learned with you this, with you, Dr. Awad, and let me tell you something. At the beginning, when I started using, I was resilient about Botox, but I learned that you are right. And I agree with you. In some cases, partial accommodative isotropia could be a good first choice for the patients. I saw great results with this Botox, and I think it's a good option. Sometimes better than surgery, less risky than surgery, and that's it.
I have one question. I will just regarding. I couldn't find any justifying reason to operate in kids less than 5 years. Do you agree with me?
Depending the case. For example, I think that if we are speaking about congenital isotropia or partial accommodative isotropia, I disagree. I think that we need to do it before 5. If we are speaking about XT, it is a different story. But regarding isotropia, I like to do the surgery. I mean, I think 5 years is late.
I mean surgical intervention. For me, all kids less than 5 years, I didn't offer them surgery. I go with botulinum injection.
Okay. Compared with botulinum, yeah. Now, you know, again, I learned this from you guys. You know, I'm coming from a school that I learned was surgery. You know, so the only choice that I had was surgery. I learned this with you guys. I learned that Botox is a available tool to be used before 5 years. In this case, I'm agree with you.
For me, all kids less than 5 years, my first line of treatment, if it is always go with try to be sure that they are using appropriate glasses, be sure that their visual acuity is at expectation. And if there is a surgical indication, I go directly with Botox injection, especially for these cases with infantile, with even ocular overaction or partially accommodative. I find that surgical intervention in less than 5 years always will end with more complication and overcorrection. Sometimes it's very difficult to measure the kids at this age. Cooperation is limited. Amblyopia is not totally corrected. And I noticed that sometimes it's not appropriate to see a patient at 6 or 7 years who has been already operated twice and is still not corrected very well before surgery was done earlier.
Let me tell you something. You know, in relation with Botox, I changed my mind regarding Botox after having the experience to join Kekesh.
Good.
And you know, in the West, people see Botox like something like the same story that in the West, people see the deep hysterectomy like a something pretty rare and that it doesn't work. And in my personal opinion, I disagree with that. I think that Botox is an excellent choice, as you mentioned, in patients under 5. It's safe procedure, fast procedure, and can be used safely.
Thank you, Dr. Sesma. Let me see if there is any question more. Did you see anything in the chatting?
They like the questions about Botox. I see that.
Yeah.
So probably you need to give the next lecture.
Maybe Dr. Awal has also good, nice presentation about botulinum. Maybe we could ask him in the future to present something about botox. There is a question by Dr. Abdullah. Is there is a limit for how many we can inject?
And you know that this is so interesting. You know, the experience in the world about Botox doses, they use usually minimal doses compared with the doses that we use here. For example, they use usually around 2.5 units per muscle, and they feel that they are putting a lot of Botox. And here we use supra doses. And when we mention that we are using these doses, 10, 12, 15 units, they say, what? They get, and you know, and the results are good. So I maximal doses that Botox, usually the biggest that I use usually could be 15, 16, around that. But
If I could comment regarding, there's few questions, and as you mentioned that you didn't have much experience with botulinum injections, since that's the case, I may just answer some questions regarding botulinum. Botox, we could inject up to 3 or 4, and certain cases you could go for more than that. I prefer for patients with infantile esotropia to go with Botox. Even if there is a periodic overaction, I will go with Botox for both, for medial recti and for obliques. If the esotropia is large, this may help to minimize the number of muscle for surgery. Chances for consecutive XT is not uncommon. It may be encountered about 5 to 7% of cases. They may end up with consecutive exotropia after botulinum. Complication with Botox, I could say not much more than just dropping the eyelid ptosis due to the botulinum procedure. The family should be aware of all the sequences that may happen after botulinum. Like sometimes the kids may complain of diplopia, ptosis. They should be ready to accept the child look after the botulinum. But we could go for 3 injection, safely, as long as the target is not achieved. After 3 injection, if the residual part of the strabismus is significant, could be corrected with surgery.
you know, Dr. Achilles is asking about the EMG. You know, at the beginning, when we start with Botox, Botox is a pretty old drug. We use the technique that transducer to get into the muscle and to check, no, with this. But today we don't use it. We don't use it. You know, we can go, and also there are a lot of studies that shows that you can inject it subconjunctival above the muscle and it works. So the role of EMG now is, especially in cases, we don't use it and we have good results.
At the beginning, when we started injecting botulinum, we started on 1991. We used to use Teflon-coated needle under the EMG control, and we find that it's very painful, especially if we do it under local for adults. We are not used to do these cases in the OR. We used to do them as a minor trauma room. But with time, we shift the patient to the OR to have better control. Second, we shift the technique to TB syringe with 30 gauge needle or 30 gauge needle. And they found it very safe and to give the same result like guided by EMG and Teflon coated needle, because the Teflon coated needle is very big and long, and I think it causes more pain than what we'd like to do. Do you like to comment?
No. Then okay. The comment is going to be that
there is a question by Dr. Dalal Fatan. Infantile is not operated until the age of 5 years. We didn't mean that we are not operating in these cases. ET could be caused by many factors. Could be infantile, could be due to partial accommodative dystrophia, could be non-accommodative. For this reason, those patients, as you know, if you look at any textbook and you read about the fusion they said that if surgery done before 2 years, the fusion could be retained. Based on our experience, if the child has no fusion being established by 6 months, there is no way, in my experience, that you could retain or regain the fusion. The best and the first line of treatment in these cases is to go with botulinum injection. It is very safe, very effective, complication-free. Bad complication only just consecutive XT or ptosis. If it's done in proper way to avoid any perforation. For this reason, my practice not to operate in kids less than 5 years in surgical technique, just they go with botulinum injection.
Yeah.
Dr. Hamidan mentioned that she go up to dose maximum 7.5. It is okay, but depend on the deviation and the case. But we are ranging between 5 up to 15 or 20 units, depending on the cases.
Yep.
Patient with poor vision who had exotropia. This is Dr. Abdullah Abdullah. You like to answer it, or should I answer it, Dr. Sesma?
Sorry, say again.
He mentioned patient with poor vision who had exotropia can be managed with Botox.
You know, well, we are doing now a prospective study about this, and Dr. Siham is doing a review also about the effect in Botox in XT. Particularly, I don't have much experience. My experience more with ET. Probably Dr. Abdul Sisawat is, or you are more experienced with this situation with the Botox XT, no?
If you allow me, I will answer it. I didn't know if Dr.
Yeah.
Awad was with us, but I didn't know. I'm trying to see his name.
Yeah, but you know, you are experienced in Botox, especially in these cases. You know,
I can't see Dr. Awad's name, but anyway, I will answer this question. Exotropia, if it's intermittent, the preferable way is to fix the vision and try to stimulate the child to have some form of a fusion. A botulinum injection, if it's given for exotropia after 2 years, is not that very effective. It may help the children less than 2 years. After 2 years, I didn't find it effective at all. So therefore, kids or for adults. It may improve the situation for a few months, but later patient will come back again with the same measurement before the Botox. Could you see any more question, Dr. Sesma?
there is operated 6 months versus 3 months for infantile. Not that that's operate 6 months or age, Shuruk, that is asking 6 months.
She's asking operate at 6 months versus 3 months for infantile is a problem.
No, you know the problem with the at 3 months or at 6 months. It's supposed that you should restore as fast as you can the binocularity of the patient. But the problem at these stages, first, is the possibility of overcorrection, and it's pretty common overcorrected because you don't have accuracy in the measures before. So years ago, I was more proactive to do surgery in earlier stage of age, but now I'm delaying the procedure because the amount of consecutive XT and the amount of inaccuracy in the measure of the strabismus was so big. So I prefer to go older patients, no? Older than 6 months.
Thank you. There's one question, and we maybe conclude after this question is by Dr. Shadal Frahi from the National Guard. She is asking, strabismus surgery after Botox injection to the same muscle does not follow conventional surgical table. What is our experience in that? For me, if the Botox is given 6 months and more, I just go with regular measurement as patient had no previous surgery.
Yeah, I'm with you. I usually 6-9 months after surgery, if the patient comes back with the deviation, I take this deviation as the regular numbers of the tables. I don't reduce or augment the procedure because the patient has previous Botox. I just do wait. The answer for this is usually I wait in 6 to 9 months, and then I do the surgeries according to the regular tables.
That's great. The reason for not doing surgery for kids less than 5 years, based on the literature, you will find that there is about 60 or 70% of patients after biomedial rectus recession, they will end it with consecutive exotropia within 10 years. For this reason, it's preferable to avoid surgery if possible. You could sometimes correct these patients with Botox alone. And there's one question for you, Dr. Sesma. It's a special consideration about those patients with surgical bucket.
Yeah, this is an interesting. Thank you, Dr. Akili, for the question. This is an interesting question because we face this situation in our hospital. Well, if you want to tell me one specific pill or trick about this, well, first, buccal can induce restriction. Buccal can induce trap of muscles, especially you could have, for example, oblique muscles involved in the procedure, and this situation can masquerade many clinical signs in the strabismus. So when you have a patient with buccal, you should approach as a possible complicated patient. So regarding my personal approach to these cases is if you need to explore, you need to check how are the muscles. If you don't find restrictions due to the scars or muscle traps. Second, if I need to do recession, I do recession and I use handbag. I avoid the scleral, crossword scleral. Sometimes if you need, if the point of insertion of the muscle is the buccal is there, you can remove the buccal depending how long it was the surgery, the retina surgery. But if the retina surgery was many years ago, 10 years ago, or you can remove the buccal. Here probably we need to call you guys, no, in retina. But in this case, you can remove it. Or in some cases, you can use this buccal as a point of fixation of the bicril. It's interesting. Sometimes I face this situation. I use handbag, and because I have the buccal at the level of the muscle insertion, well, I use this this band as a point of fixation, and I fix the suture in the silicone band in the buccal.
Thank you for answer, Dr. Sesma. There is a question by Dr. Abdul Fadda. He's asking me about how do we inject the inferior oblique muscle over action. First, I would like to welcome Dr. Al-Fadda. A long time I didn't see him. And it is my common practice to inject inferior oblique. As you know, there is a good chance for you to avoid inferior oblique surgery. I'm injecting these obliques with 5 units, depending on how much the overacting. If it is 3 or plus 4, I inject them with 5 or up to 7.5 units. I find that I could avoid inferior oblique weakening procedure, I could say in most of cases. For the season, when there is a patient with infantile esotropia and inferior oblique, I proceed with Botox for all the muscle, for the medial recti and for the oblique. And I found it very effective. I didn't have any scientific-based review, but hopefully there is a project ongoing here with Botox, and we'll try to see if there is a good result or not. I think the time is over now, and we'd like to conclude the meeting. We'd like to thank you very much, Dr. Sesma, and hopefully we'll see you again, inshallah.
Thank you, Dr. Mesfer. Thank you all for the participation.
Thank you for all the participants. Thank you.